Just before introducing our panelists, just a few notes. Today is the World Obesity Day, and I think this discussion is extremely timely. And we all agree that obesity is one of the major public health challenges that we are facing at the moment, and that's, needless to say, in the temple of cardiovascular health is extremely important for cardiovascular health. Just to give you an idea, globally, rates of obesity have increased. There are estimates that suggest 2.7 billion people will be overweight or obese by 2025. And if we look only at obesity by 2035, we are talking about 1.4 billion. So, I mean, it's a huge number. And this is not just an adult problem, it's children affected too. US, 14 million children live with obesity. And just data show that there is no place in the world where the trend has changed. I mean, there is nothing. We keep doing, we were talking with Finland, we keep doing things, but trends don't change. And we are here today because obesity is a complex problem. And during the open ceremony, the ACC president states that the wider determinants of health account for 80% of our health. So we really need to think wider, and we need to think about the complexity of the problem. So I'm very grateful to introduce our panelists today. Professor Dorairaj Prabhakaran is Distinguished Professor in Public Health at Public Health Foundation of India and World Heart Federation board member, as well as immediate past World Heart Federation Science Committee chair. Dr. Madhu Jog, he is Clinical Research Fellow at the London School of Hygiene and Tropical Medicine, and Professor Phil Shower, Pennington Biomedical Research Center, Louisiana, in the United States. And I really would like to focus our discussion today on two areas. One is to identify policy that can help to create healthy environments and how they can be adapted to the national context. And from the clinical point of view, is what we are doing enough? So I would like to start with Prabhakar. And there has been a recent CVD obesity paper, position paper from the World Heart Federation and the World Obesity Federation. And what are the takeaway points from that report?
Thank you, Chiara, and good morning, good afternoon, everyone. The recent paper by the World Heart Federation and the World Obesity Federation actually outlines the problem of obesity across the world. It gives you the burden, it gives you the problem, it discusses the complexities of obesity, the causes of obesity. It's not just a mere mismatch of energy intake and energy expenditure, but goes beyond that. The role of background genetics, the various other factors. It discusses all of those. It also discusses the differences amongst ethnicities. For example, the Asian population, BMI is not a great method of assessing obesity. It also looks at the role of central adiposity, body fat distribution, and several other areas. Thereby outlining the importance of central obesity and body fat. It outlines the management strategies both at the individual level and at the population level as to what can be done, what are the challenges in terms of advising individuals, and also the complexity of policy making, particularly in relation to the food industry and several other areas to combat obesity. So I'll stop here and come back if required.
Thank you so much. So just taking from here and thinking global and going local, if you want, Madhu, why is obesity, I mean, can you give us a bit of the context within the Ghana context, and why is considered a silent epidemic, and what has been done in the country to address the obesity epidemic?
Thank you. So I'm from the Gambia, which is a low-income country and still has an unfinished business of combating infectious diseases. So we are having an increased incidence of non-communicable disease to add to the problem. And similarly, you can say something similar with regards to the double burden of malnutrition. So we still have problems of undernutrition and trying to tackle that, and now seeing more cases of obesity to compound to the problem. And all this, to bring to context, you will understand the competing priorities of dealing with both problems, especially where one causes more acute problems and the other long term. So where do the priorities lie? So in the Gambia, uh, about 30 years ago, the prevalence of obesity in men was less than 2%, and in women about 8%. And more recently, we've seen for men about 4% and women just over 20%. So you can see that in the space of 20, 30 years, we have seen quite a big jump in all this. And the problem mainly in women, as we see, but also mainly in urban compared to rural areas. And then just to understand why it's definitely a silent epidemic, it's because there is very little done to address this, but because also it's well tolerated. In a lot of circles, obesity, especially in women, is associated with affluence, with other factors, wealth or so. So it's a problem that would require a lot to really address, given the contextual situation, especially with how it is regarded by people who are obese. They don't see it as a problem, and people tend to even strive to gain weight. So that is a situation. And then also, given the chronicity and with the competing interests, there's little done to address it at the government level. Thank you.
Thank you so much, and I apologize for the wrong name. Sorry, I'm really sorry. And I will come back to that later, but I would like to move now. We went from a like global to national and then really to the individual. So my question for you, Phil, is really, you are a surgeon and you perform bariatric surgery and for people with obesity. And my question is really, are these interventions beneficial to people living with obesity and cardiovascular diseases? That's enough.
Well, thank you.
Yeah.
And it's great to be here. And I would like to say happy World Obesity Day, but it's a very sobering issue, isn't it? It is. It's very concerning. We should all be alarmed by this, but it's important that we do recognize at least once a year. We should probably have World Obesity Day every day of the year because it's such a staggering problem. As Kiara mentioned, I'm not a public health expert. I'm sort of at the tip of the spear. I'm a surgeon, a metabolic surgeon, and what I try to do is at the individual level, enable individuals who have this chronic relapsing disease called obesity, help them control their excess adiposity by altering their gastrointestinal tract. The common operations we perform, gastric bypass or sleeve gastrectomy, and there's a good 20, 30 years of data supporting the efficacy of these interventions, not just in the magnitude of weight loss, but the durability. And there's quite a bit of data suggesting that even cardiovascular disease, can be reversed. I'll just point out a study I was involved, my former institution at the Cleveland Clinic. Steve Nissen was one of the key investigators, along with my colleague Aliyah Minion. And we looked at about 3,000 or 4,000 patients who had metabolic surgery and diabetes, and were compared to a matched group, a 5-to-1 matched group. And we published this in JAMA just 2 years ago, and we showed that at 10 years, the individuals who had metabolic surgery had about a 40% reduction in mortality, about another 40% reduction in cardiovascular events, a 60% reduction in new onset heart failure, significant reduction in cancer, a reduction in new onset atrial fibrillation. So it seems that a large amount of weight loss, and the average individual in this study lost about 100 pounds, so 50 kilograms. That amount of weight loss can transpose into significant, cardiovascular benefit and save lives. Yeah, so this is one intervention. It may not solve the world problem, but at the individual level can be very effective. And I think it's not just the surgical intervention, but the point is weight loss. A magnitude of weight loss that can be sustained is a very effective therapeutic tool for people with cardiovascular disease.
Thank you. That is really, I think you raise a very important point. Is this with the actual projection of having by 2035 1.4 billion obese people, can we really take at the end of the problem, or do we need to do something at the beginning to avoid that too many? Because maybe there is not even capacity to solve the problem at the end of the if you want, of the river, of the public health, right? Going from prevention to clinical care.
Yeah, and I think in the U.S., it's maybe out of all the countries in the world, I think we're leading the pack. Today in 2023, about 40% of adult Americans have obesity, and it is causing, and it's the second or third major cause of death in the United States. It accounts for about 3 or 4% of the gross national product, just this one disease. And it's estimated by 2035 that 58% of Americans are going to have obesity. So we're increasing at 2% per year, which is staggering.
Thank you so much. I would like to go back to Prabhakar and really think about a bit one of the actors that is the healthcare practitioner in treating people living with obesity for cardiovascular conditions. What is the biggest challenge that they are facing, that you think they are facing?
I think there are multiple challenges which the individual healthcare provider faces, but let's look at few. Let's look at what is the management plan for a person with obesity when the patient comes, when the person comes. I won't call somebody with obesity as a patient. When the person comes to see a healthcare provider. So the first thing is, almost everybody universally would believe that it is behavior change, change in the lifestyle that will benefit. Second is the complexity of drug treatment, and third, of course, is the role of surgery. Now, looking at the behavior change, when you look at behavior change theories and you want to change the behavior of people, actually there are three components that are required. When a person says, I know, so you provide the knowledge to the person. When the person is empowered so that the person can say, I can, and you create a change, a desire, so that the person can change and say, I want. If I were to use a very cliched and somewhat flippant statement, you want the person to, fast or reduce the diet, whereas the family has a different diet. So that doesn't work. You can't, while the family is feasting, you can't expect this person to fast. So clearly you require a strategy. And essentially what I think we should move is towards family or group-based interventions. And there is some evidence. In fact, we did a trial in India which shows that family-based interventions actually can reduce weight, can improve risk factors. The second problem about obesity, it's not like hyperlipidemia. You give statins, your lipid comes down. It's much more complex intervention. And therefore, there is a need to provide an enabling environment, and that requires policy. And so physicians are actually change agents. They can become lobbyists. They're the most influential people in the community. They can talk to the policymakers in terms of improving parks, sidewalks, walking paths, and things like that. That's another area. In terms of the drug treatment, it's not simple, as we all know, and many of the anti-obesity drugs have failed. Right now, we have one or two which are promising, particularly the GLP-1 agonists, but they're pretty expensive for most part of the world. So we need to look at alternative strategies. And these are really the big challenges, the cost. The second biggest challenge is multimorbidity. Obesity doesn't come alone. People have osteoarthritis, they have respiratory illnesses, they have multiple other illnesses. Now we really require a mechanism to address multimorbidity, and we should look at ways and means of providing guidelines to these physicians in terms of looking the patient in a holistic manner rather than tackling obesity alone. I think that will help.
Thank you. That's a very, very good point, and maybe we can explore. And I would like to go to Modu, and maybe then Phil also get your view in the front line. It's really about children, and as I said, I mean this epidemic is really getting to children too. And Modu, what do you think that can be done or changed within communities so that we can tackle the problem early in life? And then Phil, I'll come to you with one specific question on that.
Thank you. I think I'll just take up from where Professor Prabhakan just left it. So with children, I think it requires really complex interventions, as he said, family playing a big part. And I would like to think about this in two ways. What can we do to encourage physical activity, and what can we do to encourage healthy eating? So I think the family level is very crucial, very important in terms of what they can do, especially nowadays that there are lots of things that children are doing that encourages sedentary behavior, especially with the video games and all those things. So at the family level, some of those things are crucial to address. Also, what can families do, or what policies can we put in place to encourage healthy eating at the family level? What can be done in terms of having regular meals? How do we manage the snacks, etc.? So all those things crucial. But also the environment. This is talking about policy. What can we do to have environment conducive for physical activity, for also healthy eating? So the environment should have enough space, but also the safety in some areas also quite crucial to think about. So as you will see, it requires really very complex strategies, and this can be from policy, government levels, to the society, to the family. So all this, I guess, we will discuss further, but just to touch on some of these things and just leave it from there. Yeah.
Thank you. Yeah, we will go back to some other key elements there. But Phil, what is your experience in terms of what you see in your role and front line in terms of child and adolescent obesity? And what are the solutions, if there are, clinically speaking?
It's even more sobering with the children. Now, we are in Louisiana, which is the state in the U.S. The U.S. has the highest rate of obesity in the world, and Louisiana has the highest rate of obesity in the United States. And consequently, has the highest rate of obesity among children. So while all of us are huge advocates to public health measures, and that's the solution to prevent, unfortunately, a lot of children are falling through the cracks. One good example, just 2 months ago, I performed surgery on a 12-year-old boy with a BMI of 62, meaning this 12-year-old boy was 200 pounds overweight. Now, I operated on him more than 2 years after he began a very intensive obesity management program by a pediatrician who is board certified in obesity medicine. And despite all the drugs, he couldn't lose the weight. And this young boy had adult diseases. He had prediabetes, he had dyslipidemia, he had sleep apnea, he had a condition called Blount's disease, which means that his legs are bowing because of the excess weight on his trunk. Yeah. And this is just an example of the many children who are falling through the cracks. And they're destined. The data shows that children and teenagers that have severe obesity, they are destined to carry that obesity into adulthood unless we insert some very aggressive interventions.
Yeah, that is a very good point, and I think it goes back to what Prebaka was saying about multimorbidity and about and for me is that falling into the crack is really it's true. We have maybe the physical activity, the healthy eating, but the context in which we live or children, adults live do really allow us on those children and those adults really to have healthy diets, to have physical activity. I mean, I think we need to, and I think that we are changing a lot the narrative from the individual responsibility to society. But Modo, I completely agree with you. The family is playing a big role, but somehow we are putting the responsibility there, and how we make these families feel that we are really together in this as a society, because it's a society responsibility, the current pandemic. So so I think it's very good point. I know that we went through a first few rounds of questions, and I would like to see and ask whether in the audience there are questions that are urgent, or at this moment you would like to ask the panelists. Please.
We know now that we are the epicenter here in U.S., especially Louisiana. Is it the affluence of the country and society is responsible for this outbreak of obesity? You're from Gambia, poor country. You shouldn't have obesity problem. Or if you're going to have problem, what have we learned from country like U.S. to prevent it? Is it the social influence with wrong foods? Is it lack of exercise? What have we learned? How are we going to implement it?
Can I ask you just your name for the panelists?
I'm Dr. Karapati from Columbus, Ohio.
Yeah, thank you. So.
Okay, again, I'm not a public health expert like my colleagues here, but I can tell you the facts. The World Obesity Federation today released its World Atlas of Obesity. I encourage all of you to download it. Just go to the worldobesityday.org website. It's really amazing. It lists the prevalence of obesity in every country in the world, 250 countries or so. And if you look back over the last 5 years, 10 years, there's not a single country where the obesity rate is stabilizing. Every country, it's increasing. It's increasing. So it's very sobering. So despite the fact that countries have very different socioeconomic statuses, different cultures, different parts of the world, different influences, this is a global epidemic, and nobody's getting it right.
Right.
Madhu?
Yeah, thank you. So with regards to the obesity problem in the Gambia, so I think as countries progress, perhaps the problem will start with more affluent people, then later to the poor people. So we are at the stage where we see this problem in more affluent communities locally. And there's a possibility that as the economic situation progresses and more awareness, hopefully not, but it would, the trend would be more seen in more poor communities. But as of now, it's mainly in rich communities, more affluent communities, and more in urban areas, and in women. So it's so sad that people go to the extent of getting under-the-counter steroids just to gain weight. So because of the what's associated with obesity, beauty, affluence, etc.
Rebecca.
Right. I think that's a very important question. So the question is it related to affluence, the obesity epidemic across the world? The answer is yes and no. If you look at the history of what the dietary pattern has been, and you just look at US, in the 1700s and 1600s, on an average, the consumption of calories was something like 1,400 to 1,500 calories on an average, and there were dips when there were famines, when there were pandemics, and so on. But as we moved along, by the year 1950, 1960, it had gone up to 2000, 2200. Currently in the US, the average calorie intake is somewhere around 2800 and going up. So clearly there has been an increase. Is it all caused by affluence? The answer is no, because across all the high income countries and several high middle income and low income countries, it's the poor people, it's the people with the lower levels of education who have high degrees of obesity. In the US itself, you take the example of Pima Indians. They are the best example of the most deprived population in the US. They reside somewhere near Arizona at the Gila River area. The government provides them subsidies, the government provides them food. So people thought undernutrition was a major problem, but because of the food and other subsidies that are provided, they have the highest burden of diabetes in the world, highest burden of obesity. That is one reason. The other thing which is not well understood is the influence of undernutrition in the mother, undernutrition at the fetal life, which increases the risk because there is rebound adiposity in the kids of these mothers who are undernourished. So there's a lifelong influence of undernutrition during the first 2 years of life. It's called the 1,000-day paradigm, where the first 1,000 days, whatever happens, goes on till early adulthood and later life and increases the risk of obesity. That is the second reason. The third reason is about the dietary pattern itself. We have changed from our traditional diets, which had whole grains, which had high fiber, to very refined food, which actually increases obesity. The fourth is the understanding of obesity has emerged only recently. For the last 50 years, we have been talking about low-fat diet. But we now know that it's carbohydrate, it's the refined sugars, which are the main culprits. So that's the fourth issue. The fifth issue is messaging, because messaging is a big problem. You have different things coming out through WhatsApp groups, through media. One day this food is good, the next day that is bad, and so on and so forth. I think we have to go to very simple messaging. In India, ancient philosophers said, even if you take the nectar of life, nectar of immortality, you take a little bit of it, you become immortal. But you take it in excess, it can be poisonous. So a simple message that what you require is moderation. Don't go into these extreme yo-yo diets and things like that. That's the kind of messaging we need to think of. So there are multiple things that we have to look at.
Yeah, Phil.
I was just going to comment. Isn't it ironic? In some countries, West Africa, obesity is associated with affluence. In the Western world, it's associated with poverty. Isn't that fascinating?
Yeah, and just to give you a few numbers more, I mean, I'm based in the UK, so the data when there is a national study on children in school, so everyone in school is measured for their height and weight. In reception, when they are 5 years old, and in year 6, when they are 11. And when you look at the difference, you have 20% of kids in the poorest area being overweight or obese compared to 5% in the wealthiest areas. But then in the Gambia, it's exactly the opposite. And when you go in countries that are in transition, you see this like U-shaped, where you have very high among the poorest and the richest and low in the middle. It's like a transition. It's a curve that keeps moving. Please.
Developed countries like in the U.S. and let's compare U.S. and Denmark.
Yes.
U.S. and Denmark, for example, both are wealthy countries. The obesity rate in Denmark is 9 to 10%, and in the U.S. is 37%. I think there is a lot of government policies involved. We can buy, let's say, 12 cans of Pepsi or Coke for $3, and it costs $3 just to buy a can in Denmark. So if we do not change the government policy in this country, I mean, it will continue. This subsidizing this carb and all kind of products here in the US, I think that's probably the main culprit of obesity in this country. One of the main.
Yeah, thank you. And I think this really brings nicely to the food industry, and because I think it's there. We haven't mentioned until now.
Yeah.
And really the ultra-processed foods, the fact that we are rich in calories but poor in nutrients, so we may have obese children and adults that are lack micronutrients because what the diet doesn't include those micronutrients that then have impact on other aspects. And here I'm going to be a bit like challenging the sense that we were talking before about tobacco, and we have been able to tackle, if you want, that. But tobacco is really needs to go to zero, right? I mean, that is the target. But food we need to eat. So what do we do? And I open, so how do we move? What do we do? And how do we work together, integrate, and we work together thinking. And again, healthy foods, normally ultra-processed foods is cheaper than healthy food and doesn't require preparation, which is another very important thing when we think, for example, at single mothers that have children and they work on shift, they go back home and probably, I don't blame anyone that it's better to buy something prepared, ultra-processed, the kids eat without any complaint. And here I'm big the devil's advocate here, but what's your view?
Well, I just want to point out, one common sense strategy would be, like the gentleman pointed out, let's do what Denmark's doing, okay? However, even in Denmark, the rate of obesity is increasing, my friend. United States, Louisiana has the highest rate. We're about 43, 44% of the population. Colorado is the skinniest state, which about 30%. But guess what? In Colorado, their rate of obesity is increasing too, at almost the same rate. So everybody is sort of failing this problem, and we've really got to put some resources into this, or otherwise it's going to bankrupt countries, or it's going to be a huge health problem. We're not going to be living as long as we expect to live, at least in the United States.
Madhu?
Yeah. So I think, so this is really very educative for me as well, because what I'm hearing and what I see locally kind of very different. So we have a situation where ultra-processed foods are available only in supermarkets in the Gambia, and this is only accessible mainly to the rich people. So if you say that they may be cheaper or so, maybe a different story to what I'm used to seeing. But also looking at it from the other perspective, fruits and vegetables are quite sometimes expensive in at least my setting. And even where people grow them, they prefer to sell and get the money to get other things than to actually consume them. So I think it's a very complex thing, and perhaps whatever interventions need to be taken should be, locally relevant, culturally sensitive, and I think it depends on the local context. So this is just what I wanted to add onto that.
Yeah, and Prabhak, on this one, I think if you can think also, so have been given, so that then if you want, this is the obesity and cardiovascular disease position paper. That's, you are more than welcome. We can distribute later. But there is the consideration of the possibility to develop an international treaty similar to the WHO Framework Convention for Tobacco, and to address obesity, and where to start, and do you think is possible?
Right. I think let's just reflect back upon why the Framework Convention for Tobacco Control became a success. Number one, it involved a single vector, the tobacco company. Yeah. Number two, there was a buy-in from the community because of passive smoking. It was highlighted in terms of how it can affect others. So there was a buy-in, widespread buy-in from the community. The third was that there was economic evaluation looking at what is the gain in terms of raising taxes. And there were simple formulae. For example, you raise the taxes twice, the number of people who quit smoking will be 3 times. As simple as that. But the problem in terms of framing a framework convention for food is the food systems. So when you look at the food systems, I'm talking from the farm to the fork. So you look at what can be done at the level of the farm, at what can be done at the level of the fork, at the level of the individual. Looking at the farm, for example, if you actually look at the inflection point for the obesity rates in US, it actually started, if you go back and look at it, it actually started with President Nixon providing subsidies for cornstarch. It started with that. And that was the inflection point somewhere around the 1971-72 period. And from then on, the obesity epidemic started. So subsidies is a big problem. Second problem is the unequal trade covenants which are there across the world. Take Mexico and Brazil, for example. They grow a lot of fruits and vegetables, and they export the fruits to US. And what does US do in turn? It processes them and sells them chips, the crisps, and sugar-sweetened beverages. So that's the second problem. The third problem is the food industry itself. Somehow the food industry is not considered evil enough like the tobacco industry. So we need to look at how to handle that. There are a lot of people in ACC itself who receive grants from food industry. I mean, people get grants. The food industry deflects the harmful effects of food by saying that it is all physical activity related. Focus on physical activity. They'll give you grants on physical activity. I have refused to take such grants, but the reality is those grants are available. The fourth issue is in terms of messaging at an individual level. Like in the tobacco, they had this empower policy. How do you actually combat tobacco at the level of the country, at the level of the individual? How do you ban tobacco in public places? Lots of advisories there. In food, there are multiple voices, so you really require a cogent and concise way of handling that. So it requires a dialogue. The last point I want to make is many of the things that we say and that we do, we don't involve the consumers. We did a study in India where we asked women, what do you think of, there's something very popular in India called the 2-minute noodles. It just takes 2 minutes to make the noodles. It's very, very popular. So we said it's unhealthy. So the women said, yes, we know it's unhealthy. But why do you cook it? She says, I travel 2 hours by bus, go to my place of work. Then I come back in the evening. I have to make something quickly. And the children are hungry. You tell me what is the solution. So you need to look at employment. So it's much more complex than FCTC, but it can be made.
Yes, that's exactly a very, very good point. Again, the audience, any question or comments that you would like, please? If you could tell us your name.
Hi, I'm Mridula. Thank you all very much. Very interesting talk so far. I know this is projecting perhaps a little bit farther in the future, but climate change and environment is one of the topics being discussed here at ACC this weekend, and that has been more and more prevalent. And I'm wondering, with a lot of what we've been talking about food supply chain at the level of the farm, and with the need for perhaps more shelf stability given challenges in ensuring the food supply, changes in the environment as well, where perhaps the air quality is preventing adequate outdoors exercise. How do you see these features impacting our obesity, anti-obesity measures, for lack of a better word?
Please.
I'm going to talk about this tomorrow a little bit, but I think there are a few issues. Number one is in terms of climate change, yes, food is an important factor. Like rice cultivation is one of the biggest contributors to the greenhouse gases. But the problem is 2/3 of the world consumes rice. How do you ask them not to consume? So you require methods in terms of reducing that rice consumption, or methods in terms of reducing the population size in the world. So that's a separate argument altogether. The second thing is, yesterday I was having dinner and I got something which was, they gave a steak, small steak, but this much of mashed potatoes. And you don't eat all the potatoes, it's a waste. One of the biggest contributors to climate change is food waste. It's almost 20-30%. So we need to reduce the portion sizes, and we have to be careful in terms of giving that, because putrefied food releases methane. Methane is the important contributor to climate change. The third is how we use the groundwater, and water depletion is one of the major reasons for reducing beta carotene in fruits. And empirical studies have shown that food grown in water depleted areas have low beta carotene content, low antioxidant content, and in fact there's a reduction in the amount of fruits and vegetable consumption. So then the question is, how do we actually harmonize with the nature in terms of food and agriculture and food consumption? So there are multiple mechanisms by which you can try and answer this question.
That is really, really. Would you like to comment on this?
No, I think Prabhakan has touched on all that. What I wanted to add onto this. So I think there is also the other worry of food scarcity, especially in areas where food comes from other sources. So if there is an issue, for example, we saw in the Ukraine war, some of these challenges that we saw, that some parts of Africa, for example, were deeply affected. So similarly, if there are climate shocks or so, there is a likelihood of food scarcity of food supply, or the quality that will be received at the other ends will be affected, and indirectly affect weight and all those things. So just what I wanted to add on to that.
Thank you. Phil, do you want?
Yeah, I'm not an expert on climate change. I think it's just another element in the future that we have to consider as we try to tackle the obesity problem and incorporate any strategy with some strategy to address the climate change issue.
Yeah, and I think, yes, I'm coming. Just a comment that I think is a very, very good point. I mean, these shocks to the system because of climate change or because of war that is linked to, or conflicts area that is linked to climate change, I think that we will increase in the future. So how do we tackle is a very important point. Please, sorry.
No worries. My name is Björn Hansell. I'm a doctor from Sweden who moved to the US and California and later on to Hawaii, where I live now. So I've seen how the environment is very different that we're exposed to, but also how different groups of people have different levels of resilience to deal with that. And I wonder, for anyone who's a practicing physician, how do we handle that in our daily practice? Do you have any tips or advice? I myself find that it's important sometimes to kind of educate people of the fact that it's not their individual fault, but then still you need to empower them to deal with the situation. Do you have any advice to give around that?
Phil.
Well, one strategy is to think of obesity as a disease, which most of us probably agree here that it is a disease, and medicalize it. And there is an emerging, all of you are cardiologists, there is an emerging discipline called obesity medicine, where physicians are becoming expert in managing obesity using the various tools. And there's sort of three categories of tools. There's so-called lifestyle intervention, which takes into account activity and diet. Then there's drug therapy, so-called anti-obesity medications, and there's surgery or other types of procedures. And so I think it's asking a lot for a primary care doctor or a cardiologist to practice obesity medicine. You have enough on your plate with your own specialty. So perhaps one, not the solution, but one solution is that we need to grow this field of obesity medicine, just like we did with other diseases. 100 years ago, there were doctors who specialized in tuberculosis, or syphilis. Fortunately, those diseases are about gone. But I think we need to develop this field of obesity medicine and allow physicians to refer patients appropriately to not only obesity medicine doctors, but centers. Now, I'm in a center right now. It's called Metamore Metabolic Institute in Baton Rouge, Louisiana. And it's a multidisciplinary group of obesity medicine specialists, nutrition, behavioral health, and surgeons who are all working together under the same roof, using the tools that they have to the appropriate individual. And I think that type of model needs to be replicated in the future. That's for intervention. Now, prevention is a whole another strategy, but once an individual has reached that threshold, BMI 30, 35, the evidence that we can use preventive strategies to turn it around have so far not been very effective. At that point, in my opinion, it's time to treat, and treat early and treat aggressively to reverse the condition.
Anyone else that would, oh yes, I can see a lot, that is great, please. Yep.
I'm actually a home-based care physician, so one of the things that we do routinely is we actually do what we call a kitchen walkthrough. So we're opening cupboards and looking at the Progresso soup, and one I would share with all my fellow colleagues is I look at a lot of after-visit summary instructions, and the things we think we're saying very clearly, we're really not. The patient goes home and says, okay, low sodium diet, and that's it. That's really all the level of support that we provide. And so that would, just to sort of share my own experience, I think as Dr. Prabhakaran had said earlier, the level of misinformation and complex information that's out there is challenging enough for us as physicians, and I don't think we recognize how challenging it is for the patients when they leave our office.
Thank you. Please.
Hi, good morning. My name is Mario Ochoa. I'm a primary care doctor in New Haven. The first one is more of a comment, and I'd like to hear your input on the role of modern society as what's driving the obesity epidemic. The second part, it goes more towards what's been done in medicine and the advances. So we have great medications that could be used now. Now, what I'm seeing in the clinical practice is I want to prescribe them. I identified patients. I've been working with them to help them, tackle lifestyle changes. And then at the time where medication is indicated, then we have another barrier, which is insurance approval, or patients that are uninsured or don't have access to the medicines because they are simply uninsured. So what advice do you have for us in the clinical field to, tackle obesity from our end? Thank you.
Phil.
Okay. There was a lot in your question, but maybe I can address the issue of the barriers, of what physicians have to go through in terms of getting people access, their patients access to evidence-based treatment. That was a big part of your question, right? Yeah. So on the plus side, just over the last 5 to 10 years, there are tools or interventions that have been shown, in very well documented studies to have impact on obesity over time. But unfortunately, a lot of, healthcare delivery in the United States is based on, insurance for the most part. And many insurance companies often do not cover these evidence-based tools, which is a huge challenge. And this takes a lot of effort to make changes. I'll just give you an example. In Louisiana, I've been here 3 years. When I got here, again, this is the state that has the highest rate of obesity in the U.S. The state employees, the government is the largest employer in Louisiana, and the state employees had no coverage for bariatric surgery. And for 20 years, there was an attempt to make it available. And it took a huge effort, but we succeeded about 2 years ago. And now state employees, some of them, have access to surgery. But the same problem exists with anti-obesity medications. There's some very exciting drugs. GLP-1 agonists are available. The short-term data suggests significant weight loss in the range of 15 to 20%, which is quite profound. Unfortunately, they're quite expensive, and many of the carriers do not cover those. So this is an area where a lot of effort has to be done on the policy side to allow access for these powerful, effective interventions.
Thank you.
Well, I don't think I have much to say about that, considering the fact that we do not have some of these interventions, these medications. But I think for our local context would be more of really trying to find other solutions, public health, as at now, to address some of these issues.
Rebecca, do you want to comment on this? No. that is great, and I think this. Yep, please.
Are we doing enough to educate? Are we doing enough to educate the young children, elementary school and high school, about nutrition and the importance of eating right? We are very worried, and we have inculcated sexual education, but are we doing enough to do nutritional education is my question for Dr.
Right.
Prabhat.
So in terms of interventions in children to reduce obesity, there have been 6 or 7 major studies, mostly in Canada and a few in the US, and very few in countries like India. The sum and substance of all these studies is that you may provide information, you may provide anything, it doesn't work. What works is 2 things. Number 1, changes in the curriculum. The curriculum should include what you do about food. So that's you have to work with the education departments and change the curriculum. Second is to provide physical activity compulsorily, and in countries like India, that physical activity class is utilized for academic activity, so one should avoid that. The third is involvement of the family. Without the involvement of the family or the community, nothing will work. So I think these are the 3 things that you have.
Phil.
I'll just comment. Yeah, clearly educating children, parents, the lay public about nutrition is important. But what's also alarming is physicians. You physicians out there, how many hours in medical school did you get on nutrition and obesity? I would guess, in the 4 years of your training, less than what's on my hand is the number of hours. Yet, obesity is, arguably in the West, the biggest public health problem. So we need to educate our physicians in medical school. And it's amazing that there are many medical school curriculums across the country that have very little, if any, formal education on obesity and nutrition.
Thank you, Phil. I think there is one last question from the audience.
Is the last
You.
question? Okay. Sorry, maybe you discuss. I arrived later, so if you discuss
Can you
this,
raise- It's just because the.
okay.
Yeah,
Is that better?
That's
Yeah.
better.
If you discuss this, apologies, and you can ignore. But I'm saying you have someone from the U.S. where clearly there is a very important
Pablo, can you
obesity epidemic. So you have an obesity epidemic, but you have someone from a low-income country like Gambia and a middle-income country like India, where they didn't reach the stage of obesity that you have in the U.S. So what would you say from a public health point of view? I mean, the things that the U.S. did wrong to reach this level of obesity, not on the individual level and at the medical treatment. What are the things that countries like the Gambia and India should avoid not to reach the level of obesity that you have here in the U.S.?
Professor.
So it's a tough question. I think I don't know what US did wrong, but the marketing has been a major source. Like for example, the Big Mac costed a little bit more than the smaller Mac. The Big Coke costed a little bit more than because it was a marketing strategy to sell more, and because human mind is such that when you get you're greedy.
You're greedy.
So that's number 1. Number 2 is the agricultural subsidies, which is a very, very difficult area in the US. Agricultural subsidies actually increased cheap, energy dense foods. The third is I think the AHA and many other organizations have been responsible in terms of focusing on single nutrients and actually missing the bigger issue of moderation in what we do, moderation in the diet in terms of messaging to people. Third is the nexus between the food industry and the academia and others, which actually has diluted some of the issues. Fourth, I might disagree slightly with my colleague here, is this is a social problem, and making it a disease is useful in terms of managing, but actually puts away a lot of people. So we need to have some kind of social messaging. Those are the things which are the takeaway for me. Apart from that, in India, there are specific things that our BMI is not very high as compared to the US, but our metabolic problems, diabetes, etc., are extremely high, and there are other reasons, other things that we have to look into.
And I think just to add one thought, the industry clearly has an important role on the obesity epidemic. I think that's, for me, undeniable. But it's the car industry as well, and how cities have been set up, and the lack of physical activity, which, of course, in the US has been, many of the cities have been set up just to drive and not to walk. And that's something that has a huge influence in terms of the built environment.
So I forgot, I just wanted to add one thing. For US to reach this level, from the Industrial Revolution to now, it took almost 250 years. The epidemic started somewhere in the 60s, so it took 200 years. For a country like India, it's just taken 50 years, from 1947 till now. And that's because we blame urbanization, globalization, etc. Urbanization is part of any society. The difference between India and the US in terms of urbanization is, and that's a learning for us, our urbanization has happened in a very chaotic manner. So this happened in a more planned manner. So those are some of the things, good things that we have to learn. Of course, there are many bad things which have happened. And I just wanted to, maybe if you're going to give me 30 seconds in the end to summarize.
Yes,
So
I need 30 seconds each to...
So can I summarize now?
So 30 seconds,
Okay.
where we go from here, 30
Right.
seconds.
So I think my core message is that we are living in an interlinked world. So what happens in one part of the world affects another part of the world. What affects one system affects the other system. Just to give an example, we have large amount of animal farming for food. What does it do? It does grain diversion. So there are famines. There are areas where food is scarce, like in Gambia, for example. It leads to global pandemics. We saw the COVID-19 pandemic. It leads to the global pandemic. And more importantly, it leads to global warming. The IPCC, which got Nobel Prize in the 1990s, empirically estimated that if the whole world became vegetarian for one meal in a week, not more than that, the global temperature will come down by 1 degree. So that's the power of what we can do at the level of upstream. So I just wanted to end with a cliched statement by one of my mentors. He said this in some conference a few years back. At no point in history, human beings have been forewarned of the catastrophe that we face, but we are also forearmed with our solutions. So I'll stop there.
Thank you. Madhu, 30 seconds.
Thank you. So from this session, what I really appreciate is that we have different problems, different situations in a different context. So I think whatever solutions we have, we can learn from each other, but it's very crucial that whatever interventions we take, we have to take into account the local context. And I think in all this, poverty should be addressed in order to really get anywhere with this. Thank you.
Thank you. And Phil, your
Yeah,
30
no,
seconds.
I agree with my esteemed colleagues. This is a global epidemic. It has profound geopolitical implications for the next century. I agree, a global effort, a cooperative effort is probably the best solution. It's often difficult for countries to cooperate. We've seen examples, but there are examples of success. We've talked about smoking. So I really think the solution is going to be at the global level of a cooperative strategy to prevent this problem. In the meantime, however, as a clinician, as one who sees one patient at a time, I don't think we can ignore the people that are already inflicted with this condition, whether you call it disease or whatever you call it. And there are tools now available that are effective. You might think that they're expensive, but let me tell you, the most expensive way to manage obesity is to do nothing. because then you're talking about downstream, extremely expensive interventions, heart bypass surgery, stents, you're talking about dialysis, on and on and on. So the most effective, cheapest way is to intervene early. Thank you.
Thank you so much. I would like to thank our panelists and also the audience for being so engaged with this session. Thank you so much.